session of today. First of all, I would like to thank my teacher, Dr. Divya Mehrotra ma'am, for giving me this responsibility of moderating this session. And it's an honor, indeed an honor to welcome my teachers and respected chairperson for this session. The first chairperson is my teacher, Padma Shri Professor Shadab Mohammed sir. Sir is former dean and currently head of the department at King George's Medical University, Lucknow. Sir has a vast experience of more than 30 years in the field of teaching, training, and research. Sir has published innumerable papers, book chapters, and books to his credit, and he is chief editor of Traumaxilla, a journal which is exclusively dedicated to the maxillofacial trauma. Apart from prestigious Padma Shri Award, he is an UP Ratna awardee. Sir has received Lifetime Achievement Award by UPMSI. Sir is fellow of various international associations like Royal College of Surgeons, Glasgow, is a fellow TC Whitefield, and so on and so forth. The list is endless. The second chairperson is my boss, Professor Dr. Gaura Singh. He is a dynamic principal and head of department at Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow. Sir is a fellow Academy of Dentistry International and has vast experience in the field of maxillofacial traumatology. He has many national and international publications to his credit, and he is associate editor at National Journal of Maxillofacial Surgery. We also have two elite maxillofacial surgeons from our fraternity as co-chat coordinators with us. Dr. Chandresh Jaiswara, one of my senior, he's working as professor at the Department of Oral Maxillofacial Surgery at IMS BHU, and second chat coordinator is my friend Dr. Ami Agarwal. He's associate professor maxillofacial surgery at King George's Medical University. So before moving ahead to the session, I would like to make a few announcements. I would request all the participants to keep themselves on mute mode, and we'll have two question sessions. One 20 minutes after the commencement of the presentation, we'll take a break and we'll have questions. And the second question session would be at the conclusion of the presentations. So I'll request all the participants to forward their questions through the chat box to the chat coordinator so that we can have a smooth functioning of the presentations. And poll questions would also be streaming. So I would request all the participants to fill in those poll questions, and we'll shortly have the results of the poll questions as well. Now I would like to request our respected chairpersons to introduce our esteemed speaker of the day and announce the commencement of today's session. Thank you. Over to you, sir.
Okay, good evening, everyone, and welcome you all to this webinar. And I have been given a task to introduce Dr. P. Anatanarayan, who is one of the famous oral and maxillofacial surgeon. And currently he is professor of the oral and maxillofacial surgery at Meenakshi Ammal Dental College, Chennai. And he's also a specialist consultant, maxillofacial and orbital surgical services to the Shankara Netralaya and Arvind Eye Hospital, Chennai. And he is examiner to the Royal College of Surgeons of Edinburgh and Ireland. And his special interest includes craniofacial and dentofacial deformities, TMJ surgeries, and orbital surgeries. So today he is going to give webinar on this orbital trauma and this thing, and I think it will be very beneficial to all of us. Welcome, Dr. P. Anatanarayan.
Thank you, sir. It's a pleasure to be amongst you. Thanks a lot.
It's my pleasure to introduce moderator of this session, Dr. Madan Mishra, a dear junior alumni of KGMU and COTS Davangere. He is an Indian and international board certified oral and maxillofacial surgeon, ATLS instructor, presently working as professor at Sardar Patel Postgraduate Institute of Dental and Medical Sciences, Lucknow, under my headship. So over to you, Madan.
Thank you, boss. I would request our chairpersons to start the commencement of the session, sir.
I have put in the poll questions, if you can announce for that.
Please start.
We have put in the poll questions for all of you. There are 5 questions. You just click on the best suitable answer. Anand, would you like to read the questions for the audience?
I'm sorry, ma'am. I don't have it in front of me.
Right. Can you not see it on your screen?
No, I can't.
Okay.
Of course, I have a copy of it. If you want me, I'll.
I put the poll question. Can you see it now?
No, I still can't see it, ma'am. I can only see the handout.
To see.
That's okay, ma'am. I'll just read it from what I have.
But then
I can relaunch once.
Okay, please.
Yeah.
Now, yes,
Yeah, it's on.
we can see.
Okay, we'll just have 5 questions which are objective based. The first question is mechanisms by which intraoperative navigation sensors work include all of the following except. So it is a single answer you need to find out. The second one is a similar question. Of course, it's been wrongly phrased, so I'll just make a change. Methods used for intraoperative imaging include all except. So again, it's a single answer that you need to pick. So it's methods used for intraoperative imaging include all except. The third one is guidance stents can also be used as fixation devices while using VSP, virtual surgical planning. Is it true or is it false? Fourth question is intraoperative navigation produces radiation exposure. Is it true or false? And the fifth question is frameless stereotaxy refers to. You'll have to choose one of the following. So these are the 5 questions. And at the end of the talk, I think you will have it once more being broadcast so that you can make up for whatever you've left out here. Thank you.
Richa, would you please share the result once it's all done?
Yes, ma'am. So we'll wait for, we'll like continue the poll for 2 minutes and then. Ma'am, you're recording the session?
Yes, I am.
It's actually nice to see the results because this is going to tell us how to tailor our talk. So I'm able to understand how much of this is comfortably understood by the audience. So I think this is good feedback for me also. Okay. Okay, I see that the first one is split evenly. The second one again has a varying split. The third one is something everybody is sure of. So I think most of the audience has used it themselves. The fourth one, okay, is reasonably okay. And the fifth one is fine. So I think most of these questions would be answered in the due course within the lecture. So don't feel perturbed if you're not getting it right. The idea is basically to get this process across. By the time you finish the talk, if you're able to understand this with clarity, I think I would deem my effort a success.
कैसा दर्द हो रहा है आपको? दर्द हो रहा है, आपने फोन किया था, कैसा दर्द हो रहा है?
Please mute yourself. The audience.
Ma'am, 45% of the people have voted. So should we end the poll or wait for some time?
No, we may end.
Okay. These are the results.
I'm surprised. I can't see these results.
Ma'am, you can click on the polling icon again on your.
Okay.
So everybody else is able to see that the results are on the screen.
Ma'am, I think, okay. Are the right ones marked with red?
Yes.
Oh, then I think we'll have to change the answers, ma'am. I'm sorry, I'll send you the answer key again.
Okay, so that's not the
That's okay. We'll rerun it. It makes it better, actually. We shouldn't have declared the results now. We'll declare it at the end.
Okay.
So I'll take you through the results myself. That's not a problem.
We'll run through the same poll again after the presentation.
Yeah, so absolutely. I think that's fine.
Yeah, please. I think Anant, you may take over. You may start.
Okay.
Yeah.
So can I just minimize this poll box, ma'am? Yeah, I think I'll minimize that. Fine. Can I start sharing my screen?
Yes, please.
Okay. There we go. Is it visible?
Yes.
Yes.
And my audio is clear?
Yes.
Okay, so good evening to you all. I'm really happy and honored to have this opportunity to talk by the program organized by one of the leading institutes in India. I mean, as a postgraduate, even I have dreamt of KGMC Lucknow, to be very frank, because it's got quite the legacy. So it's indeed an honor. And my topic for today, I've just modified it slightly to make it more comfortably suited for my approach. It's computer-assisted surgery in orbital and facial trauma. So that is the rephrasing that I've given. My name is Anant, and I work from Chennai in south of India. So most of you are familiar with it, I guess. And if you're free, please join me at any point of time to share our experiences here. My sincere thanks are due to Professor Divya Mehrotra. She is the one who's mooted the whole concept, and to Professor Shadab Mohammed for all the support that he's been giving to this program, and to the entire department of OMFS KGMC Lucknow, which again I stress is quite well known all over India. So what would be the scope of my lecture? And I'll start with a definition, a simple definition of what computer-assisted surgery is. Then I would try to elaborate on the elements that are included in computer-assisted surgery. The concept and functioning of intraoperative navigation, because from the polls I was able to understand that intraoperative guidance is one thing which most of the audience is not familiar with, and I should thank Dr. Divya to actually have prompted me to spend some extra time on trying to conceptualize the role of intraoperative navigation for the sake of the audience. And the last one is a practical workflow for CAS in clinical surgery from my limited experience of what I have. Contrary to what people understand, there is a lot of shift in the way computer-assisted surgery is being worked up in today's surgical scenario. So we will have a look into that also. What exactly is computer-assisted surgery? So it is a surgical concept which involves the help of computer aid in either planning, guidance, performing, or assessing of a surgical process. So that in a gist is a computer-assisted surgery. What all does it involve? Basically, it involves creation of a virtual image of the patient. You have image analysis and processing. It can be used for diagnosis, preoperative planning, and surgical simulation. The added benefits are surgical navigation, which has been there for the last 10-15 years now, and robotics is slowly creeping in. It's not yet taken big form into the field of maxillofacial surgery, however, but in the years to come, I think robotics will play a major role in the expanded spectrum of computer-assisted surgery. The most important thing that I want to emphasize here is that not only do we get good results by doing preoperative planning and surgical simulation, but outcome assessment is a major facet of computer-assisted surgery, which is being less used. In the early framework, we all think that it is only an aid to perform surgery, but no, a big part of computer-assisted surgery can be used to do outcome assessment so that we can actually bring about a major change in our quality of outcomes that we create. Now, just to take you through a data sheet of what all can be done. First, you start with the data set, which is the DICOMs that we usually obtain from the CT. Then you create a virtual model, which all of us know. Then you have analysis and processing. That is what splits the whole concept into different forms. You can decide on which platform you want to use it. You can either use it as a diagnostic platform, a planning platform, a simulation platform, intraoperative guidance platform, or an outcome evaluation platform. So that again is elaborated below. You have different methods of using it. So I will just take you through just for completion's sake. So when you're looking at CAS for diagnosis, the advantages are accurate representation of the clinical problem. You have a much better understanding of the clinical problem when you're looking through reformatted images. Now let's all try to understand that reformatting not only gives you better perspective, but also it enhances the available information. Now, what do you mean by reformatting? Most of the, this is basically for the PG students who are here. Try to understand that CTs generally happen in one plane. Okay, generally it is axial plane. So when you convert the axial plane into multiple formats, as in sagittal or coronal, it becomes reformatted images or multiplanar images. Remember that CTs are generally taken in axial, where MRIs have their individual planes taken. So you can ask for a sagittal MRI, you can ask for a coronal MRI, and you can ask for an axial MRI. Well, CTs generally are taken as axials and then reformatted and given to you in different forms. So this is how it goes. Gone are the days when we used to see CTs in films. This is the trend, and I strongly advocate all the postgraduates to get this into your systems. Do not have a concept of looking into films anymore. It does not give you adequate information. Remember that a film can maximum squeeze in about 20 or 30 sections of what you want to see, but the face in its own, or the head and head till the chin point from the vertex, is going to give you about 400 slices. And when you see 400 slices, it gives you enormous amount of information. So this is my sincere request. All the PGs, boot your systems and then have DICOM viewers, PACS packages, so that you can reformat your images in any form and then get an amazing degree of information from them. The next major breakthrough was construction of 3D models. So these are, again, these add three-dimensional perception. The earlier one is you see everything in 3D, but it is visualized as 2D images, but you can assess them in 3 different planes. But here it is actual 3D representation, which makes a sea of change when you are perceiving any a skeletal landmark, especially for our purposes. I mean, when you're talking about trauma, especially, the skeletal platform is much better visualized, considering the fact that the face has very thin bones and occasionally we do not see them in much clarity. We may miss a few fracture lines, we may miss a few things, especially in the medial orbit or anterolateral wall of the maxilla, thin areas where we may not perceive it in a single section. We might want to see multiple sections and then try to find out whether there's a fracture or not. And this has certainly been a boon to all of us, where you have 3D formatting with good resolution. We can pick up even the most minute of fractures. But again, a word of caution, never make your diagnosis on 3D, reformatted 3D reconstructions, because they do have a lot of artifacts. Generally what happens is the blemishes are removed by whoever is manning the PACS program, and this may cause a lot of information to be lost. So get a rough guideline on the process, on the problem, based on the 3D reconstruction, and go into the finer details with your multi-formatted images. So that would be my recommendation for it. Now, when you're coming into preoperative planning, CAS provides a major help in optimizing the workflow. That is one. And the second thing is you are able to troubleshoot for potential problems. So this is where it acts as an important step. Not only does it make your theater sequence better, you know, the people are always, when you learn from your teachers who are experienced surgeons, they always tell you, never go to the theater and then plan. You know, the planning has to be done much ahead. It has to be rehearsed in the mind. The steps have to be in place so that when you go there into the theater, you're not in for root shocks. You know, this can happen even for acute trauma. I wouldn't accept anybody who's saying that acute trauma, you just go jump in. No, today it's not the situation that was there in the 1960s, where people had only X-rays. Now we have CTs. By the time the surgeon reaches the theater, you have all the things provided there. You have CTs, you have MRIs, you have diagnostic reports already ready. So you are prepared. So there is no excuse for going underprepared. So one, CAS provides an optimum sequence or workflow for your surgical sequence. And the second one is it does help you in troubleshooting. You can see potential disasters happening and then try to evade them if your planning process is good. Now, this can happen with 2 forms. One is, I've taken only the gist of trauma here, so bear with me. I'm just corroborating in terms of trauma and not in terms of reconstructive surgery or orthodontic surgery. So in trauma, you have 2 forms. You either have physical models like what you have here. This is a reformatted image from the PACS program, and then this is a physical model, a handheld model, which is called an STL model or a rapid prototyping model. Now, the second form, which is slightly more advanced, is this, what is called as a virtual model. Now, try to understand the difference between a reformatted image, which is there here. This is what is a reformatted image. This is very commonly available in most of our PACS programs. Any DICOM viewer would give you that. But this is the next form of your virtual modeling, which is very essential. where you can actually segment the model, you can move it wherever you want, which part of it you want to assess can be taken in separate. And of course, these need much more advanced softwares to work with, but they are certainly worth their weight in gold. So this is the second form of modeling. So you can either have a physical model or a virtual model. The next step is surgical simulation. What does surgical simulation offer you? It offers the best form of feedback. You know, whatever you do, feedback is the most important thing, because if you're able to get feedback, you can always progress to the next level of surgical betterment, you know, if I could say betterment. So feedback is the most important response that we seek from whatever we do. So surgical simulation is able to give you that feedback to different forms of manipulation and handling that can happen during the process of surgery. And the second one is you have the huge array of options that are available to you. Now, let us say you want to try one particular sequencing, and you feel that let us be ready with a plan B. You know, for example, let me put it straight. All of us are worried about panfacial trauma. Yeah. Let's say you have about half an hour to 45 minutes before your panfacial sequencing starts, and you want to try out different things. If you have these softwares in front of you, all it takes is about 15-20 minutes for you to perform that degree of planning. You can see which fits where. You can see whether you want to try a top-down process or a bottom-up process. You want to fix the mandible first. You want to fix the midface first. What structures are remaining? How will you get your projections right? Now, these are fantastic options that are available in today's world, and that is all thanks to the process of computer-assisted surgery. The most important one, which I'm going to stress on today, is intraoperative guidance. Intraoperative guidance is a fabulous tool by which you can predictably, that's the key word, you know, that's the key word, predictably transfer a pre-op plan to the surgical site. So that is called guided surgery. So you have a plan in place. All of us know that we can do fantastic plans. You do the plan. How are you going to translate it into real-time surgery? How are you going to take the process into the theater and then place it on the patient? So that is intraoperative guidance. And guidance devices can not only be imaging devices, but they can also be physical devices like stents or fixation devices. Now, when you consider intraoperative guidance, positioning devices are the most commonly used ones. So for example, let's say you have a fracture, you can make a positioning stent, or you can combine the positioning stent to double up as a PSI or a patient specific implant, and can be used for fixation also. And you can have stents cut up for your better outcomes. Let us say, this is of course a very simple process, but the same can be utilized for orthognathic surgery also. So this is in a trauma setting, but it can also be converted into orthognathic. Let's say you want to get a condylar repositioning device, it can be formulated in a very similar plan, so that you don't make mistakes while repositioning your sagittal splits, not only for the easy movements, but also for the complex movements when you're doing rotations. So this is the advantage of intraoperative guidance stents or positioning devices. This, for example, is a lingual bar which has been customized onto the occlusal wafer. So these are things by which you can actually control your transverse widening in trauma. You can assess whether you've got the mandibular arch in the right place. You know, these are things that you can actually perform and then check intraoperatively to make sure that your planning is right. Now, when you're looking at devices which can double up as fixation devices, not PSIs, remember, need not be the ones that are custom printed. You know, PSI stands for patient specific implant. That is all. So patient specific implant need not be a milled one. It need not be a milled one or a custom printed one. It can be even a simple plate which has been bent on the patient's model to make it customized. It's that simple. So a stock implant is straight, and you're going to take it and bend it in different forms and create a PSI. So there are different methods by which you can perform your own customized guiding stents stroke implants for fixation. And the simplest method that most of us are very, very familiar with is the rapid prototyping models, based on which we perform our model surgery. Now, let us say you have a trauma patient here. This, for example, is a secondary trauma. I specialize more in secondary trauma, so you will be seeing a lot of secondary trauma here. I don't do much of primary trauma. My forte is secondary. So here is a zygoma fracture which is malunited, and it's about 8 months old. And then you take an STL model, you perform your model surgery, reposition the fragments wherever you want. This is the simplest method, and then custom adapt your plates. So even that forms a sequence for PSI. So ultimately, this particular plate here, which was stock earlier, has now got converted into a PSI. The next step is when you have a CT scan and then when you perform the surgery virtually. Here there is no physical model in hand. You do a virtual surgery, virtual planning. In this particular patient, it's actually again a malunited zygoma. You can see that it is a unilateral fracture, so the other side is free for us to use. So by virtual surgical planning, you mirror the image and then put it on the right side. There is no practically done model surgery here, and then you get a STL model which actually has the mirrored model in your hand, so that the defect is already taken care of. Whatever you do as steps in the model surgery is already performed by the mirroring process, and then you custom bend your implants on it, again giving you a set of PSIs. This is also a PSI, this is also a PSI, and this is also a PSI. So in your hand, which can be used comfortably to reposition your zygoma or whatever bone which is involved in that particular fracture type. The last process is the most advanced one. Here again you can see a malunited panfacial, and you have a virtual surgical platform. Here there is no model surgery, no plate bending. The only difference is you are customizing your implant into a milled or a 3D printed titanium implant, which acts as a positioning stent as well as a fixation device. So this is the last step in that particular hierarchy. The first one is physical models. The second one is virtual model and hand bending. The third one is no physical model, only virtual surgery and virtually designed and custom printed implants. So this is the hierarchy in which intraoperative stents and positioning devices come in. Now I'll just play a small video clip here for clarity as to what is the treatment sequence that we follow in our center for our planning. Most of you would be familiar with this. This of course is a software called GeoMagic Freeform. That is what we use for our planning. And then we integrate the STL model into our intraoperative guidance system, which is the navigation system. You can see that here we are assuming that the patient's left side is normal, though it is actually injured, but it is seemingly normal and better than the other one. You have to match one to the other side. So we choose the minimally adjustable, minimally affected side as the normal. And then that is mirrored onto the other side. Segmentation is done and superimposed. Then you actually perform a surgical simulation of the existing fracture site. This can be done with haptic feedback. What is being used is a haptic saw. You can see here. The best part about a haptic saw is it's a fantastic training device. You can actually feel the density of bone when you're manipulating a haptic saw. So I think most of you youngsters who are interested in computer-assisted surgery should get a hands-on demo of a haptic device. It's a fabulous thing. When you, let's say for example, you cut through the mandible for a sagittal split, you will see that there is a marked difference between the cortical resistance as well as the marrow resistance. So that's the advantage of a haptic saw. So you can see now that the image is superimposed, we're getting reasonable symmetry. And once you are happy with the symmetry, what you need to do is you start designing the implants or the positioning stents. So that would be the next step. Yeah. So you can see that you create a customized implant and then add the screw ports for that, depending on how much of bone you have. This is very useful because in some cases where you feel that the bone is not adequate, you can always modify based on the available density to alter the screw positioning areas. So that's a generation of a PSI for you. And the advantage is you have pre-formed STL models even for available stock implants. Now this is a anatomical implant from Stryker. So you just borrow their STL form and then take it inside and see whether it fits. If it doesn't fit, you have to modify that. But it does make planning significantly easier and more predictable. Now comes the major part of intraoperative guidance. So we've seen intraoperative guidance in the form of stents and fixation devices. Let's move to the next higher level, which is called as intraoperative imaging. Now, the whole concept of intraoperative imaging started in the 1990s with the active use of ultrasound methods. Okay, that's been quite commonly used in the 1990s, not by our units, but more for research purposes. So, ultrasound was the earliest one used. It could detect fracture lines and to a reasonable extent provide some information about gross malalignments when you're looking at big bones. Finer bones slightly difficult to manage, but gross bones it can. And I think the best publications were in terms of uses for arch fractures, which was the most relevant in maxillofacial literature, because that is one place which we hardly see. You know, you have to make a big approach to reach a small area. So generally ultrasounds were used more for that. And the similar concept was used for CM guidance. Now, surprisingly, most of us, if you notice, who are all doing trauma, would take the zygomatic complex as the simplest, one of the simplest fractures to fix. No, but it is not. The zygoma is a fabulous piece of bone which is articulated in 5 places and has a potential to shift in different forms. Okay, it can shift in 6 planes. It can be anterior, posterior, or superior, inferior, and mediolateral translation, as in linear movements, as well as pitch, roll, and yaw that you study in orthognathic. So it is one bone that is actually capable of confusing even the best of minds. And imagine putting that into a secondary situation. Forget the primary. The primary, at least you have certain articulations still remaining. Put that into a secondary situation where the bones are hibernated and you don't have your normal articulations in place. Then the zygoma is going to be a nightmare. So that is where the CM came into play, and it started playing a big role in certain units for the management of zygomatic complex fractures. Then came navigation, which was borrowed from neurosurgical as well as spine surgical centers. And again, the onus for navigation in trauma was primarily for the zygoma as well as for the orbit. These are 2 areas which were pretty confusing. The zygoma because of its potency to move in different planes, and the orbit because of its hidden nature. You can't completely expose the orbit and then look for things. It doesn't happen that way. It's limited exposure, and a lot of things have to be done through that limited area. You have to go under the globe and then manipulate it between the infraorbital rim and the globe. Not much of area to work around. The medial wall is even more worrisome and bothersome. So these 2 areas became the center focus for navigation assisted surgery. The last one, about 2013 onwards, is the big advent of intraoperative CT scans and MRIs. Again, borrowed from neurosurgical equipment, but now in active use in most centers in Europe. So before we go into how navigation works, let's try to understand and contrast the role of navigation with something we already know. Most of us are familiar with how a C-arm works. In most centers, we have a C-arm, which is otherwise called as a video fluoroscope. Now the C-arm has these issues when we handle them. One, it is 2D, though it is real time, it is 2D. 2 is it has lesser definition in terms of finer surgical details. Now, when you say finer surgical details, I'm not talking about the cortical lines and buttress lines here, as you see them. They look fine. But let us say you want to see it inside the orbit, then you can't see it inside the orbit. Let us say you want to completely visualize the NOE complex and then make sure that you're reaching the right place. Let us say you're passing a transnasal canthopexy and then you want to see where it is going. You can't do all that with a CM because it's going to be that much more difficult. It has cumbersome instrumentation. All of us know that we have to carry lead sheets, and it's a big process turning the whole thing around here and there. You know, it's cumbersome because it's a huge device and it has to be rotated, pivoting on the patient's area of interest. And it is often, like I said already, it is useful for ZMC and less value intraorbitally. The biggest disadvantages that I see with CM is, one is no VSP. As of now, there is no scope for integrating virtual surgical planning into the CM system now. Okay, there is something called the OARM. We'll come to that later. But as of now, as it stands today, it's very difficult for us to integrate VSP into CM, into most CMs that are available today. And then the next one, which is very significant, is radiation exposure. You have huge amounts of radiation which is being used in that in the theater and OR. Imagine you're going into an orthopedic theater. Most of you would have gone into an orthopedic theater. They just keep on shooting you know, 30 shots, 40 shots for all their procedures, maybe 2-3 nailings and one implant placement, and you've shot more than 50 shots inside. So that is an enormous, humongous amount of radiation, and that is a significant problem. Now, contrasting that to what is intraoperative navigation, one is it provides 3D imaging. So all your navigation movements are seen by you in this format. You have the coronal, you have the axial and the sagittal views, as well as the 3D view. So you have all these views available in front of you. I will of course take you through how the system works. So a multiple planar formatting is already readily available. There is high definition depending on the scan resolution. So if you want a very, very fine resolution to be noted in your screen, make sure you take 0.6 slices, 0.67 slices, or even a 1 mm, basic 1 mm thickness is sufficient to give us the degree of resolution that we all seek in our surgical procedures. The advantages what I see are, one is it can be used in most of the areas which we are interested, orbit and midface injuries. VSP is a major addition when it comes to intraoperative navigation. Most of your surgical planning can be exported into the navigation console and used intraoperatively. And this is the major plus point. There is no radiation. You can take n number of references and still there is absolutely no radiation exposure here. So that is what I want you to understand. Some of you might be thinking navigation is similar to intraoperative CT. No, it is not. So hence it is radiation free. Now the next thing is contrast navigation to the next higher level, which is intraoperative CT. Having both is a boon. Try to understand that. If you're able to shell out about 6 crores, you can have both in your kitty. That's valuable assets. So having both is the biggest boon and would be the best situation for most of us. However, very few units are endowed with this kind of luxuries and capabilities. But remember just one thing, intraoperative CT is the best when it comes to the advances in VSP and CAS as of today. But let us say you have a complex situation where you feel that the positioning of your device or implant or bone is going to take a little bit of time and it is challenging even with intraoperative guidance, okay, like complex defects. Then for repeated exposures and repeated visualizations, intraoperative navigation is better because there is no radiation. Instead of taking 20 CTs, you can keep on checking with intraoperative navigation whether you've reached your target, and then as a final shot you take a check CT. So that is why I have said intraoperative navigation and intraoperative CT together, what we call as smart ORs today, smart ORs. So that would be the best concept to have in your armamentarium, but it is still a far-fetched for most of us. So when you're looking at a situation for repeated exposures, the ION scores better. Now, just to take you through how compact these CTs have become. So this is what is called as an O-arm, and it is that compact. A single person can wheel it into the theater and attach it to the OT table. So that is how the system works. Of course, it comes with a heavy pay package close to about 4 crores. Now to show you how, what is the difference between intraoperative navigation and CT. Now let's see, this is Google Maps. Most of you are familiar with Google Maps. And when you're going to search for my clinic, you're going to see that it is Anantan Dental and Facial Surgery that comes here. So you have a map here and you're taken to a specific place on the map. That is all. You don't have anything more than that. But yes, if you have GPS, it will guide you here. So that much of guidance you can have. You'll know that your car has reached Anantan Dental and Facial Center, which is supposed to be in this place. Now imagine that I'm going to shift my clinic and I'm going to demolish the building. Okay, my clinic would still be marked here on the map, but you cannot see whether the building is still standing upright or is it down. Now that is the difference when you see between intraoperative navigation and CT. Now this is intraoperative CT for you. Not only will it give you the position, but it will also give you all the topographical features that are there nearby. So you can see my clinic, you can see my terrace, you can see the trees around it, and you can see the houses around it. So if I fell a tree, or maybe I'm demolishing my house or the house nearby, you can see it on CT. That's the difference. So dynamic changes of structures, both skeletal and, if the resolution is good, soft tissue, can be seen on an intraoperative CT. I hope you're getting the point, right? Dynamic changes real time in terms of structures, both skeletal and soft tissue, can be seen in an intraoperative CT, while in intraoperative navigation, you will only see whether you've reached the place. Has anything changed there? You will not know. So that's the significant difference I want you to note, and I will take you through the process as we go. So let's get into the basics of computer assisted navigation surgery. History, it used to be called as stereotaxy, where it was frame based stereotaxy. That was the earlier form of navigation systems which were used by the neurosurgeons. Now it has become frameless stereotaxy, and that is how it has evolved. So the answers for your earlier question is frameless stereotaxy is otherwise intraoperative navigation. There are different types of intraoperative navigation. You have electromagnetic guided, you have ultrasound guided, you have optical source guided, and these are the three common forms. Of course, the ultrasonic guided is not being used much. It is more with electromagnetic and optical source guidance these days. If you want a better understanding, you can have a look at one of our articles, which is good. It gives you a comprehensive outlook of what navigation systems are available. And then what is the instrumentation? It's not very cumbersome as and huge as in a SIAM. This is a beautiful compact system which comes with a viewer, which comes with the sense optical source, and then you have the working console, and then you have the other small components which are in the form of the optical source, which I've already shown. You have a patient tracker which needs to be fitted onto the patient, and then you have a pointer tool which is held by you in hand. So this is all is needed. You don't have the huge instrumentation that comes along with the SIAM, but you have, this is all you need to hold in your hand. Okay, it's a very small tool which looks more like a stylus of one of our tabs, and then this is fixed on the patient's body, wherever usually it is the cranium. And this is what happens when you use intraoperative navigation. This is the pointer tool. The blue line which you are seeing in all the images, the reformatted images, is the navigation tool. So when you hit the posterior ledge and then press the tool onto that bone which you are seeing, and you want to check whether it is the posterior ledge or not, then all you need to do is, whatever is the bony landmark that is available, place your tool on that, and then in 3D you can see where you are. So that is the advantage that you have with navigation. Remember that the CT is already stored inside and it is not a fresh CT. So when you're looking at how the concept works, it's very similar to the GPS. You have a map, you have a satellite system, you have a local network tower, and you have your car in which you are moving. So that is the system, and this is the analogy for that. The optical source becomes the satellite, the patient tracker becomes the network tower, and then the pointer tool becomes the car. So when you are navigating within the patient, what happens is the satellite gives you signals which is pinged onto the local network tower, and the local network tower is able to give your relative position within the map, which is the CT scan. So that is the workflow by which the navigation concepts work. So there are different steps that you need to follow. Of course, if you read in literature, it says it adds a lot of time. For a trained person, it takes about 25 minutes to set up the navigation console. And yes, it is quite a steep learning curve for the beginners. But once you get a hang of it and the theater staff know it, it's very easy after that. The pre-op workup involves all these steps: importing data, selection of the procedure, registration planning, and procedure planning. And then the intra-op components involve setting up of the system, validation and calibration, patient registration once more to match the CT, and then a navigation mode activation. Let's skip all these things. We'll take you to the important part. The procedure selection is two forms. Either you can use mirrored reconstruction, which is already available in the console, or you can use virtual 3D planning, which you're all familiar. Like what we use in virtual platforms during the preoperative planning, you can actually sit and work on it in the navigation console itself. So this is how it works. This is a video which is shot on the navigation console itself. where we've actually inserted a implant into a patient who requires a complex orbital secondary deformity correction. And you can see that the implant is in position already set in place by our virtual planning systems. And when we are inside the theater and then using the imaging for guidance, all we need to do is see whether our pointers are hitting the yellow line, which signifies the implant position. So if we are able to match our contours with the pointer to the yellow line, that means we've set the implant in position perfectly. So this is just an example to show you. You can see that here we missed out the posterior ledge, and then just as a corrective measure, yeah, we've got the posterior. So that is how it is useful. You can actually readjust your topographical anatomy when you're operating within the field, a limited field, to know whether you are actually in the place you desire to be. Now, the biggest advantage is you can also do your VSP planning outside and then take your not only stock implants, but also convert your PSIs into STL format and then import them inside. So this is a PSI which has been imported inside for 3D planning and execution. And that is the PSI in place. You can see very minimal ledge which is there, and the depth of it was approximately about 42 millimeters. So that makes it complex. We will discuss the case later. What do you use for registration? You can use fiducial markers. Fiducial markers means you have radio opaque items which are inserted into the patient when taking the CT itself. That's why they are called fiducial markers. The next one is mask registration, which is non-anatomical registration, where a mask is placed on the patient and then that helps you register. All these things we will see as we go across the steps. These are fiducial markers. For example, you can use dental implants. You can use screws also. You can place a few screws in the patient's dental arch and then use them as fiducial implants, fiducial markers. And then the next is, like I said, mask registration. That is automated completely. This is how a mask registration is done. You place the this is a disposable mask. It's a single use. So you place the mask on the patient and then align it to the given format, and the computer on the navigation system does the rest. You don't have to do anything else. Automatically it matches the landmarks and then registers the patient onto the CT scan. So that is how mask registration is done. The next is anatomical registration, where you are selecting a few predetermined points on the CT scan first. So on the CT scan, you're marking a few points, and then on the patient, you will mark the same points in the same sequence, so that the computer on the CT so that the computer on the navigation console is able to identify the same sequence and the points that are marked and match it to the patient's CT scan. So this is how it is done. You can see that there are already 6 determined points, and these points will again be placed marked on the patient. This is the insertion of the patient tracker, which I said earlier works like a local network tower. So it's basically a skull pin based tracker. If you have a Mayfield clamp, you can fix it onto the Mayfield clamp and use it if you have a habit of using Mayfield clamps in your theater. Otherwise, this is a skull post which is quite comfortable. Only thing is you will have to take consent of the patient to make a small stab incision and then fix it up. And remember that there were 6 points there. So usually this is what we do for orbital surgeries, easy ones. Medial canthus, lateral canthus on one side, medial and lateral on one side, other side, and then the tip of the nose and the frontal nasal suture area on the soft tissue. So these are the areas that we standardly use, and once the same sequence and points are matched, then the CT is calibrated to the physical patient. Okay, sorry about that. Yeah. Supposed to get this. Okay. Okay, so this is surface registration. So you can see this is how navigation works. As you move on the patient, it automatically moves on the CT scan. So that is how the system works. This again for your comfort level is the pointer tool, which is a small one which you can hold in your hand, and this is the patient tracker. So as you move the pointer tool anywhere, that is automatically mapped onto the patient. So this is another part of showing whether your registration process is correct or not. This is called service registration. Then the final one is activation of the navigation mode. So this is how the navigation system looks in the OR. This is the surgeon's view. As you touch the probe onto the patient, you can see that the patient's anatomy is reflected on the screen with the pointer pointing here. That's the blue line, and the pointer automatically tells you where are you. Okay, so that's the surgeon's perspective in the OR, and that is the on-screen view. So if you have trainees nearby and you want to see or demonstrate certain landmarks while you're operating, this is the best view. Ask the trainee to go and have people peep into the on-screen view so that you can understand different landmarks as you go inside some critical areas. So that is how the on-screen view looks, and this is real time. You can see that I'm touching the medial ledge and then seeing whether the positioning of the implant is right. You can see I wanted to focus in that. That's the posterior ledge. You can see that the pointer tool is exactly placed there, and in real time that is where you're touching. So this is what gives us confirmation as to whether we have done a correct surgery or not, and is it in the anticipated position or not. This is the easiest form. So the plate is already in place, and then you are locating locating the pointer at the posterior most aspect of the plate along the floor to medial wall junction, and you are checking whether it falls in the right place. You can see that the pointer shows the posterior ledge on the coronal, on the sagittal, and the medial wall edge on the axial sections. So that is how the system of intraoperative navigation works. It does not shoot scans, but it shows relative positioning of the pointer in terms of whatever scan is already fed into the system. Okay, next one. Now the last one is something which is of much importance and interest for researchers, and I know KGMC has a big legacy for top of the line research. So this is one area which you might want to look into very seriously. CAS for outcome assessments. Okay, these days they are becoming extremely popular, especially with the advent of and popularity of image fusion analysis. So with image fusion analysis, you can do outcome assessments. For example, this is the discrepancy between the actual as well as ideal positions of an implant which is placed without navigation. I just wanted to show you how it looks. So the green one is the ideal position, and the red one is where we have actually placed it. You can see that the implant has in a floor with medial wall component. The medial wall is actually the challenge. For anybody who does orbital surgeries, they will understand that the medial wall is actually the challenge. And you can notice that without navigation, we've actually pushed it more into the ethmoids rather than keeping it within the orbital confines. So this is a good way for us to get positive feedback and help us learn better. So this is an important facet which I want to emphasize in this talk. Now the next thing which is the most important one is, what is the algorithm that we prefer to use when we are using our fancy gadgetry, computer assisted surgery? How do we use it? In what all situations can we use it? And what is the best method of getting the optimal results from these systems that we possess? Now, contrary to a popular belief that virtual and physical models are the easiest and they should be used for every surgery, I have borrowed this concept from Professor Schramm's algorithm, which is available on AOCMF, and this is exactly what we follow. In fact, intraoperative CT should be the baseline. Every unit in the world should have intraoperative CTs, because that's the lowest level of or rather the most needed form of intraoperative guidance that we need, that is required. The next one, I've cut that off because I don't have intraoperative CT. So I have intraoperative navigation, and hence I will take you through a process as to how I use it. First, I have the CT data, then I perform the pre-op planning, which I've already shown as to how I do it. And the third one, when it comes to intraoperative guidance, it depends on the difficulty grade. You have the routine cases where you can go ahead with non-guided surgery. I'll take you through examples for all of them. Non-guided surgery. And then you have the mild to moderate difficulty grades where intraoperative navigation alone is enough. And then you have the complex or highly difficult grade cases where not only intraoperative navigation is used, but also you need either physical or virtual models in assistance, so that our planning is good and we are able to replicate certain movements and then feed that movement into the intraoperative navigation system and match it. So here it is non-guided surgery. Here it is actual on-table intraoperative navigation without any big major planning. We just check, let us say I want to check whether there is, I'm going into the medial wall more or not. So I just place the navigation probe. I know it is in place. I come out. There's nothing more than that. The last one is very complex procedures where I want to make complex movements. Then the movements are already replicated in the model, performed as a model surgery, virtual or physical. And then that planning is converted into an STL format and fed into the navigation computer, and the navigation is made to match to that. So in my opinion, the navigation, which is the most expensive one, does not come at the fag end. It has to be used up front. So that is the baseline. And model and physical models and virtual surgery, which we commonly use on a daily, day-to-day basis, is what comes at the end. Because please understand that having an STL model and then contouring certain things on that and then saying I'm able to replicate it in the theater is actually not true, because we do not know whether we are actually able to replicate what we planned in the theater. That is what is the key mistake that we all make. We plan everything well, but sometimes the translation in the theater goes wrong. So this is the algorithm which I follow, and I'll take you through case scenarios. Scenario one is a seemingly normal patient. This is a rare white eye blowout in an adult. So you have absolutely no symptoms. Patient is perfectly looking fine. However, when you see the CT scan, you'll understand that she's got a large scale fracture. Now, when I say large scale, don't look at one aspect alone. Look at the other aspect. It is usually measured in terms of area lost. And she's got a large scale fracture and restriction and diplopia in superior gaze with tethering of the muscle to the posterior ledge. Now, this is a very simple and straightforward case which already gives you a posterior ledge. The medial wall is intact, no big challenges. So this is one case I wouldn't mind going straight away and then doing it as a non-guided surgery. And that's the outcome of the patient. You have the pre and the post scans here. It's sitting nicely on the posterior ledge because you can see it. There's no challenge in that. And then the medial wall contour is established to perfection. So these are very simple cases where no VSP is actually needed. Then come the next degree of difficulty. You have the mild to moderate difficult grades. This is a patient who's a secondary orbital deformity with more than a year and a half lapsed from the primary surgery. He's actually had a surgery earlier. You can see the scar here. You can see a infraorbital incision there, and he's already had orbital reconstruction done. What does he have now? He has diplopia in primary gaze, restriction in superior and lateral gazes, enophthalmos, hypoglobus, and exotropia. Exotropia means your pupil is facing lateralward. So you have, it's all evident here. You can see hypoglobus here, you can see enophthalmos here, and then you can see exotropia also. Now, this is a slightly more difficult case and more challenging. And let's have a look at this. Yeah, that is a CT scan. You can see that the earlier plate is actually into the sinus. It's not reached posterior at all. And again, on the coronal section, you can see that it is floating. Basically, the problem is the posterior ledge is far behind. It's near about 36, 38 millimeters, which is quite difficult if you're not used to secondary surgeries in the orbit. So that would make it into a challenging scenario. And in this particular case, I want you to appreciate this. There is tethering of the medial rectus here at the posterior end of the broken, even though it looks intact, it's actually broken. If you see and compare it with the opposite side, you'll understand that the medial wall has to come here. Remember that the medial wall doesn't fragment and then fall down like the floor because of the ethmoid air cells. It holds, it's more like a shock absorber, and then it takes a different contour. There is tethering of the medial rectus here, and that is what is causing the exotropia. And then there is the tethering of the inferior rectus here to the posterior ledge. So unless you actually locate the posterior ledge, you can't release the inferior rectus or the medial rectus here. So that is what makes this case more challenging. and for which you use navigation. So the second step is, when it's easy, you go non-guided. When it's slightly difficult or moderate difficult, you go with navigation alone. So this guy was done with navigation alone. There was exploration, removal of earlier implant, release of medial rectus and inferior rectus, and the floor reconstruction. You can see that the levels are much more better. You can see that the hypo is corrected and the supratarsal hollowing is not very evident here, which means there is significant enough correction also. And then you can see that the exotropia is also gone. His pupil is actually looking straighter. Here it is much more evident. So that is the level of enophthalmos correction that we've achieved, and that is the realignment of the pupils in the right direction. And that is his scans. So you can see the earlier implant here and the ledge missed out. You can see that the ledge is completely bridged here with the secondary implant, and you can see the beautiful floor and medial wall contour here as opposed to the earlier situation. So this is the betterment that you can get with navigation. And the second one, I want to give you a facial trauma also rather than orbits alone. So sometimes I get a lot of patients, high flying patients, who come for minimal corrections. Now, we all know as surgeons that when you're looking at huge corrections, bad to good is very easy, but good to excellent is very difficult. And this patient came to us for a correction of a zygoma. Without the markers, you would assume that this zygomatic complex fracture is reasonably well fixed. But what I want you to notice is this: he's got depression of his malar prominence when compared to the opposite side, and he's got buckling of the arch, and then he's got fracture of the root of the arch, which has also come out. This guy was very interested in getting his transverse facial width corrected just by a few millimeters, but he was very insistent. And then he had evidence of clinically perceptible enophthalmos. So this is him after correction. So that is the degree of correction you can achieve even in the form of millimeter precision. You can get it right. And I want you to appreciate the scans. So that's the malar prominence on one side, that's the depressed malar prominence, and you can see that both the malar prominences are perfectly in symmetry. Look at the arch form, balanced, and look at the root of the arch. So this is the degree of perfection you can achieve with navigation. So who is interested in navigation? Navigation is for people who seek perfection. You can get this in most of our hands very comfortably. But if you want to translate from here to here, if this is the kind of practice you have, then you need to start thinking about navigation and intraoperative CT. The third one, very complex problem. You can have, this is a redo orbital reconstruction with NOE with no posterior ledge, and has to be done only with a PSI because the stock implant won't even reach. So this is the earlier done reconstruction. That's the limited amount of posterior ledge that we have. There is practically no ledge here. You can see that, and the implant is floating into the sinus. This is, I wanted you to see why it is more complex and difficult. That's the stock implant, which measures about 36 millimeters. And here we have to go up to around 42, 44 millimeters inside. So this is a PSI which has been prepared. You saw the PSI being included into the navigation system earlier in the form of 3D planning. And this is him post. Of course, I'm sorry, I have not seen him because he's a Bangladeshi. He is yet to come back to me after follow-up. So you can, the only thing I wanted to appreciate is the correction which has been done and the fullness which is there. Okay, more than that I can't show you anything. Look at this, the fullness and the change in the orientation of the palpebral fissures. That is what is the clinically perceptible idea here, with an NOE correction also. And of course, the CT scan is something I never miss. You can see the beautifully placed sinusoidal reconstruction of the floor. We've exactly touched where we want to be, and that is the implant in on the model. So that is why you need model, planning and execution with navigation for a complex case rather than the other way around. Model is not the first choice, navigation is the first choice. Model plus navigation means you need a more complex case. So the next one is a facial trauma case other than orbit. This is a complex facial deformity which where the patient presented with orbital apex syndrome, and he came to us for emergency decompression, and of course the emergency itself was 3 days later. Again, this guy was also from Bangladesh. So we had ample time. In my setup, I can get a model within about 18 hours. So what happened was, the moment they transmitted the CT to me, I got the model ready. By the time he landed in Chennai, I had the model ready, the plan ready, and the VSP already shuttled into the navigation console. That is his CT. You can see that the optic canal is completely closed, obliterated because of the sphenoid merging inside. And that's the shift of the superior orbital fissure because of the greater wing of the sphenoid completely fractured. So that is him about 7 days post decompression. I won't say every case works like this. Please don't misquote me here or misunderstand my concept. Decompression works in selected patients without any predictability. You can either choose to decompress, you can put them on steroids, or you can do nothing. Still, the result may be the same. So don't misunderstand my concept by saying if you do early decompression, you'll definitely get vision back or your nerves working back. This guy, in fact, got his vision back almost. He came up with a very, very bad vision, and he landed up with significant improvement in his visual status and acuity. So not every case is a success story like this. However, I wanted to show you this case as to how dependable and predictable decompression can be made. Okay, the physical process of doing a decompression and not the result. So I want you to have a look at the scans again. The pre here, optic canal completely obliterated, post after reduction, the superior orbital fissure realigned. So this is something which we can do with model assisted navigation. So this is my set of cases to help you understand what are the grades of difficulty that you would want to correct with what modalities of computer assisted surgery and VSP. So this is the final positioning of the patient. Imagine that this is almost a primary trauma. I would call this primary trauma because we had to get the whole thing sorted out by the time he landed in Chennai, and which was less than 2 days. So this can be done. I know most of our centers these days have their own 3D printing machines and all that. So it's not a big thing for us to say that it cannot be done in primary trauma. A normal tabletop printer takes about 8 hours to print a hemizygoma. So even that can be done, and then I think we can give more predictable care to our patients. So that pretty much is the end of my talk. These are the two hospitals where I do most of my work. This is Arvind Eye Care in Chennai, and this is Shankar Nitralaya, which is more famous and known to most people across India. If you have a chance to come to Chennai, please do visit us. Spend some time with us. We'll be happy to host you. And if there are any doubts, I will be happy to take it now. Thank you for your patient listening, and thanks for the wonderful opportunity given to me by the organizers, Professor Divya Mehrotra, Professor Shadab. I really appreciate your inputs here. Thanks a lot.
Thank you, Dr. Anand, for sharing your experience or thoughts with us.
Do we have any doubts? Can I take any questions?
We have one question from Professor Jitendra Arora from Saraswati Dental College. And then what is the role of...
I think I finished exactly on time. 59 minutes is what mine says.
Exactly. Yes. So we have one question, sir, for you by Dr. Jitendra Arora.
Hello.
Hello. Can you hear me? Hello. Hello.
Dr. Madan, I'm not able to hear you.
Oh, is it fine now? Is it fine now?
Yes, we can hear you.
Okay, I think there's some problem from your side, sir, because I think...
Anand, can you hear Madan?
Yes, ma'am.
Are you able to hear me?
Yes, I can hear you. I can hear Madan.
We can hear you, sir.
Okay.
Ma'am, one question from Dr. Jitendra Arora, that what is the role of computer navigation in osteotomy procedures or in facial asymmetry? So that is one question, if you can convey this, because I think there is some problem on his end.
Oh my God, I'm not able to hear anybody.
Okay. Anand, can you hear me? Anand, can you hear me? No, he can't. Okay, why not?
He is asking whether this navigation surgery, osteotomy procedures, or for facial
able to hear
asymmetries.
Okay, look at the chat box.
You.
There's some problem.
Anand sir.
Dr. Madan, I'm not able to hear anything at all. I just hope you were able to hear my talk.
Yes, yes, yes.
Of course. You are not.
Am I audible to you, Anand?
Box has the questions. Okay. Where is the chat box? Okay, I don't know whether I'm able to, everybody is able to hear me,
Yes.
but let me see whether, ma'am, I'm not able to hear you.
Okay, so why not? I don't know.
I can only see you speak.
Okay, so maybe
Okay,
your
the
audio.
first question is actually, there is one from Dr. Jitendra Arora, role of computer navigation in osteotomy procedures or in facial asymmetry. Okay, it has a huge role. I don't get feedback. Okay, please don't misunderstand me. I'm not able to get any feedback. So I'm just giving you the answers. Computer assisted navigation, yes, has a big role in osteotomies and facial asymmetry corrections. We use it, but because this particular presentation was tuned for trauma, I have not added anything in relation to reconstructive or corrective surgery. However, if anybody is interested in further queries, my email is given there. You can pass it on to me, and I'll be happy to answer it in another forum or in private. We can hear you clearly now also, fine. Okay, but I'm sorry, I'm not able to hear anybody. Thank you so much. Are there any other questions? Can we use navigation for removal of tumors from difficult areas? Yes, very much. Navigation has a major role in tumor surgery. The only problem is navigation is very dependable in terms of skeletal confines. Okay, bone does not move inside, so it's very comfortable for us to use it in terms of skeletal relationships. When you're using it in terms of soft tissue relationships, because of retractors, the soft tissue moves, then you will not get the soft tissue delineation properly. However, skull-based tumors are very, very comfortable and amenable to resection with navigation. And another important facet is, if you look at neurosurgical literature, navigation is one of the best methods to plan your approach. Let us say you have a difficult area to approach. Let's say you have the skull base, you're aiming exclusively for the area around the foramen oval or something like that, and you want to plan a transmandibular approach to the foramen oval. You want to see whether the direction of access is good and what all structures will you encounter. Then for access planning in tumors, navigation is extremely good. But if you have skeletal confines, then yes, you can use navigation to see whether your margins are clear or not. Anything else? What specifications for CT scans do you advise for PSIs? Okay. Now, when you're looking at specifications for CT scans, the best is go for 0.6 mm cuts because that will give you adequate resolution for most of the areas that you're looking at. Remember that in CT scans, the more resolution, the more thin slices you gain, the better resolution you get for most of your stuff. And the more resolution it is, the better quality of virtual planning you can do, because your model, which I showed you, the virtual model, most of the service providers will do what is called as masking. Masking means they remove the blemishes. When you have less slice thicknesses, 0.6 or 0.3, then the chance for them to use this blemish masking is less. Your model itself will be that good. Okay, so that's the difference. What majority of your practice is involved with model surgery or in virtual surgery? Okay, now this is a good one. So my experience with manual model surgery stopped about 7 years back. Now most of my planning is virtual surgery, and but I use less of printed PSIs. Like I said, I make the stock implant into a PSI with a virtual surgery based STL model, if that is going to answer the question. But yes, I use a lot of navigation. So it is for my, like I said in my algorithm, it's non-guided surgery. The next step is navigation guided surgery, and the last step for complex problems is model plus navigation surgery. When you manipulate fracture segments virtually, how do you make sure to carry out the same movements intraoperatively? Ravi, I think this is the same question which I answered very clearly earlier. You have something called as positioning stents. So whatever manipulation you do, you want to make the fracture fragments fit into that stent. That's the method by which you are able to achieve reasonable translation of your planning on the computer to the patient. So once the stent fits, it's like orthognathic surgery, you know, like whatever movement you do, ultimately if it fits into the wafer, then you know that the mandible or the maxilla is in the right position. So that's the method by which you do here also. Only thing is, instead of making it a dental wafer, you are making a skeletal wafer or a skeletal stent. I hope that is able to answer your question, Ravi. Can you explain the role of navigation in exact reconstruction or approximation for aesthetics? Okay, now this is a difficult question to answer, because aesthetics, Santosh, is two forms. One is called as skeletal based aesthetics, which most of the maxillofacial surgeons follow. I am actually slightly averse to that. If you look at my orthognathic presentations, you will find that I don't give too much of onus on cephalometrics. Cephalometrics are but a guide for me. Okay, I will make a clinical diagnosis and I will try to match it to the cephalogram rather than the other way around. I don't look at the ceph first and then get a diagnosis. So for me, soft tissue profiling is very important. I base a lot of my work on Arnett and McLaughlin's analysis, so which is basically soft tissue reconstruction. So if you're looking at aesthetics and navigation, not much of a role, because aesthetics is primarily soft tissue. But if you want to reconstruct your skeletal framework properly, like I showed you a zygoma here, where the zygoma had to be moved by 3 or 4 mm, 3 millimeters with very minimal transverse widening, then those kind of fine movements you can achieve with navigation, which should reflect in the soft tissue if I'm able to convey it properly. I hope you're able to understand that. Can we couple navigation surgeries with telesurgery and robotics? Okay, now telesurgery is one and robotics is different. So this is from Dr. Amya. Okay, so let me answer this, Dr. Amya. Telesurgery means you are getting inputs through teleconferencing and then performing the surgery. So that is one facet. Robotics is entirely different ball game. Robotics, when you are using robotics, you don't need navigation, because the robot is already programmed to take you to a particular area. So yes, telesurgeries can be combined with navigation if you feel that you need input from a more experienced surgeon or a senior surgeon who's guiding you in the process, and you want confirmation. Let us say I'm a trainee surgeon and I want to use navigation to do a complex procedure with my boss sitting in Lucknow. So I'm going to call my boss in Lucknow and then put him on video conferencing and then say, look boss, I have reached this area by navigation. Do you think it is correct? So my boss says, oh, the video conference, yes, it's right. Then I go and plate it. So that is telesurgery with navigation. But robotics, you don't need navigation at all. Robotics itself is self-navigated. If it is okay for you. Any intraoperative, postoperative complications you have experienced? Yes. This is from Major General Nandi. Thanks for the question, sir. This is a very interesting question. Now I will explain this in a very clear and simple format. Please understand that navigation, again I'm stressing, shows only skeletal changes. It does not relate to soft tissue. Okay, and yes, we've had one case where it's a huge defect. It was a 3-wall defect which we had to reconstruct with a stock implant because the patient was not willing for a customized PSI. For my surgery, it might sound funny because I use navigation everywhere, and the costing for navigation for my patient is only 3,000 rupees extra. So it is a very subsidized costing, and so navigation is practically free for me. So I use it for all my patients. But in that particular patient, despite our navigation, when we took a post-operative CT, we found that the implant was intraconal on the medial side. Okay, so yes, this can happen because on the navigation screen, the mirroring and the implant position was exactly where it should be. Even in the post-op CT, when we mirrored and superimposed the images, the right and left were exactly in position, but it did not take the soft tissue counterpart for a large medial wall defect, and the medial rectus was actually medial to the implant. Okay, so intraconal placement of implant on the with navigation assistance. So yes, it can happen. That is why intraoperative CT is better than intraoperative navigation, and when used together, they give you the best results. I hope you are able to get the point, sir. I hope it is clear to you. What materials are you using for PSI? Okay, currently I use titanium. I'm planning to give a try. I've got 2 patients waiting for whom I've already fashioned PEEK from, because PEEK is quite expensive when it comes from foreign suppliers or multinationals. I'm trying it with somebody from Maharashtra. So this is going to be my first experience. Otherwise, normally all my PSAs have been titanium based. Anything else? So I don't think I will be the best person to speak comparing PEEK and titanium. And, in my experience, let me just give you a word of advice. PSAs are good, and but unfortunately, the quality of planning with PSI, I'm really sorry that we are not able to interact through this forum. It's a very disheartening thing, because these are things where I would need a lot of input from seniors who are sitting across, especially Dr. Divya ma'am and Dr. Shadab sir. I think they will understand what I'm trying to tell you. PSIs need a lot of planning in terms of designing. Okay, when you're planning a PSI, let us say I'm planning an orbital PSI, I'm planning only with the skeletal framework in my computer. I'm seeing the bony defect, I'm just bridging the bony defect with the PSI. Who is going to compensate for the exposure? When you have a large implant, let us say I'm making an implant which is 42 millimeters by 44 millimeters mediolaterally, how am I going to push it into the orbit? That is something we forget. That is where the foreign planners, I have worked with the Martin group as well as Materialize group. They are fabulous. They have surgeons there guiding them, and the surgeon will tell you, this is a large implant, you cannot push it into the orbit through a incision, so segment the implant into 2 pieces with guiding grooves. So this is one thing which I have faced as a major drawback in my practice. My earliest PSIs are all total utter failures, because I've had to throw them off because they just wouldn't go inside. Okay, then I had better sense in requesting for help from some of my friends in Materialize and KLS, and they helped me saying, please plan it as multi-segmented implants so that you can push them inside. So this is a piece of advice that I would like to give to most youngsters who say PSIs are the panacea. No, they are not, at least not in India. Be cautious with your PSIs for major things like cranioplasty defects and things where there is abundance of exposure, where you can just open everything and then slap it on. It is good, but not in intricate surgeries. Role of ophthalmologist in orbital surgeries. Okay, that's a nice question, which I usually like, and I enjoy answering this question. My relationship with not an ophthalmologist but an oculoplastic surgeon. Okay, all my colleagues are oculoplasty people. Ophthalmologists unfortunately have very less exposure in orbital work, and they are most of them shy off when you call them to the theater for any kind of help. While oculoplastic surgeons are a good set of people to have by your side in certain cases. But if your level of experience is good, I do 95% of my cases on my own. Okay, even in ophthal setups, though I operate in Shankar Nethralaya and Arvind, I do my cases on my own. If I need them for a specific purpose, like let us say there is a case where there is severe scarring and partial avulsion of a muscle, and I want it to be handled intraoperatively, I will call a strabismologist. I will call a oculoplastic surgeon. Let us say there is already pre-existing traumatic optic neuropathy, and then I want to go very close to where the nerve is. I want to do redo surgeries. I've had at least 10 or 12 cases where I've removed implants from intraconal space, and there, trust me, it's a tough life. The implant will be actually touching the optic nerve. So in those cases, I would feel very confident in having an oculoplastic surgeon with me, more out of the medico-legal issues in place rather than anything else. Though now we've grown very fond of each other. You know, you start developing mutual respect for your colleagues. I have tremendous respect for their experience. I have learned all my transconjunctival and transcaruncular approaches from them, and vice versa. Now most of them are very adept in doing external approaches. You know, my oculoplastic surgeon is very good in doing a coronal approach, which is surprising. So that is the way it is. Otherwise, a role of an ophthalmologist is good in terms of checking for certain things in the initial stages. Otherwise, it's not a big role. In certain indications, like I said earlier, where you find that the optic nerve is actually shows a traction because of the nerve, implant which is already fibrous nearby, not touching it, nearby, then in those cases, or some case where you need help with muscle resuturing, a partially avulsed muscle or toned muscle or something like that, yes, definitely. But it will improve your quality of understanding by a huge margin. What is the failure rate of navigation surgery? What is the failure rate of navigation surgery? In my hands, it has been 1 in 123 cases. Like I told you, 123 cases approximately I've done with navigation now. And I have got one case in which we placed the implant intracorneally, like I said. You know, the medial aspect was lateral to the medial rectus. So I had to go back inside, retrieve the implant, and then re-dissect it and push it inside again. So if that answers. Ma'am, I'm actually doing lip reading. Okay. So if there's anything else, please shoot it, or we can close. I'm really sorry that I'm not able to interact. It's such a shame. I hope you're able to listen to me. For a moment, I got scared that maybe I was not coming across. Let me enlarge your screen, then maybe I can read your lips better. Yeah. So is there anything else, ma'am, that I can help you with? Perfect. And thanks, Dr. Madan, for being around. And Shadab sir, thanks a lot for the opportunity. The rest, I just hope you're able to take some good messages from here.
Well, thank you so much, sir, for your.
Ma'am, you'll have to type your message.
Yeah.
Thanks to all. Yeah, it was wonderful.
So I think we should.
I really enjoyed this, though it feels as if I'm watching a Charlie Chaplin movie. You know, like I can see all gesticulations, but I can't see anything. I can't hear anything. Okay, ma'am. Wonderful. If there's anything else, I mean, if there isn't anything else, I will sign out. Thanks a lot, and stay safe. Bye-bye.